So what are some tips for getting good images on patients? So the first is really to roll the patient. What side do we want to roll the patient onto in order to kind of optimize our view? Right. So actually we want to move them onto their left, because by rolling them into the left supine, it kind of pushes the gallbladder, falls forward and becomes more anterior. We want to always check the neck of the gallbladder, and I'll show you some examples of that. If we think that there's a chance that the stone, if we identify a stone, if we think it's obstructive, sometimes we can sit the patient up and see if it moves, and I'll show you an example of that. And then finally, just sometimes if you have a very, very difficult patient, sometimes it's even hard to tell what the gallbladder is versus a vascular structure. And some people talk about using color flow to just kind of make sure that they're in the right spot and they're even looking at the gallbladder. But here's an example. I just want to show you. You can see this stone is kind of down in the neck, and it's a little bit, when you pause and you see the shadow, it's easy to see, but you can see how it could be overlooked. And it really is important to go all the way through the structure and really identify the neck. Here's another one where you can see the stone sitting right in the very neck. Now that's a big one, and hopefully you wouldn't miss it. But again, you want to make sure you interrogate all the way through. I talked about sitting a patient up and seeing a stone move to prove that it's not obstructing. Here's an example, again, from our archive of a stone that's rolling as the patient moves. And that gives you, some assurance that if you identify just a single stone, that it's unlikely to be obstructing. So let's talk about a few pitfalls. I think still the biggest pitfall that I encounter in reviewing scans is people confusing bowel gas or getting hung up in bowel gas or it obscuring their view. So again, remember, like all bowel scans, we want to apply kind of steady, constant pressure to get that gas out of the way. We will from time to time see polyps, and I'll show you an example of that. Also, there is WES, which we'll get to in a moment. And then also just this concept of free fluid. Remember that you can have free fluid around the gallbladder, and you want to make sure that you're not just seeing ascites. So here's an example of some stones. You can see the stone there is easy to see, but initially I tried to find an example where you can see how bowel gas can kind of play havoc a little bit. And so this is about positioning the patient, some steady pressure, some different views, and looking at from some different angles. You just want to be aware that the bowel gas is around there and not have it act as a false positive. Here's an example, and you can see in this clip there's a gallbladder and there's a structure inside it. It comes off of a stalk, and so it kind of looks like a polyp. Not all polyps are going to strike you as being on a stalk right away, and so what you're really going to try to chase down is whether or not there's that shadow, because the shadowing is often what helps us identify a stone from a polyp. Now, I had mentioned something called WES. Does anybody know what WES stands for or what it is?
West Edmonton Mall.
Yes.
Oh, wait.
So WES is wall echogenic shadow. And so what that means is that sometimes you'll have a gallbladder where you have a number of stones, and then the gallbladder is collapsed. And so that essentially all that's in your field of view or your image are the series of stones. And as you can see here, sometimes it can be hard to identify. It can look like bowel gas, but you can see there's a distinctive shadow coming down out of that collection of stones, but you don't see any gallbladder there. Here's another example. So how does this fool people? And how is it a pitfall? It often, people will overlook a WES and they'll say it's going to be a false negative because they misidentified a collection of stones simply as bowel gas or just overlooked it because they've never found the gallbladder. Okay? I just wanted to speak kind of briefly about the common bile duct. I think years of emergency room productivity have been lost trying to look for the common bile duct. There are scenarios, theoretical scenarios, where a provider may do a scan. And in this scan, you can see a large gallbladder. You can see the common bile duct enlarged. This is the double barrel sign. And then the artery, I believe in this case, below. The common bile duct, there is always that theoretical concern that a stone is trapped somewhere within the common bile duct system and that you're only going to be able to identify the common bile duct. In most of the anecdotals, I think in talking to other providers, it's very rare that someone will make a diagnosis of cholelithiasis based purely on a common bile duct without any other symptoms. And again, this kind of plays into the piece of the puzzle. So I'm not sure there's, and especially in pediatrics, I don't know if there's a lot of good data to suggest we need to hunt down the common bile duct and make that part of our scan outside of just scanning the gallbladder. But I do think it's important that you recognize a common bile duct as big and enlarged. Some people use different values as you grow. I think there's some metrics where if you're under a certain age, it can be less than 4 millimeters, but most of the time we think about less than 6 millimeters is being kind of normal. Once you get above 6, especially above 10 millimeters, then it's definitely abnormal. Here's another view and another image, and in this one again, you'll see that large structure come up underneath, again, the double barrel kind of sitting down there. See that double barrel? That's a enlarged common bile duct. Here's an even clearer one that'll just kind of show. Now I don't have any clips where someone stopped and measured, unfortunately, but these are just some examples where they were enlarged. Do you see that double barrel? So I think when you're looking, I think it's fine to kind of sweep through, but in my estimation, by no means is a scan incomplete if you haven't identified the common bile duct or you haven't measured it. So I also just wanted to mention kind of what's new. And if you look through the literature, I think this study has a lot of interesting merit. It's from a journal that I subscribe to and read regularly. But this work by Blackwood was a retrospective of 170 patients. And what they looked at were patients that went to surgery for gall disease. And the pathology showed that 87% of those patients had signs of chronic inflammation, so that they had had an ongoing course of chronic inflammation. But only 3 of them, based on how they presented and the ultrasound, identified any inflammation prior to surgery. So their point was that there's probably a lot more chronic cholecystitis in the pediatric population. It's probably underappreciated. And so it's just something to think about when we're scanning and kids have right upper quadrant pain. So something a little bit new. But again, we don't have a lot of good data about that.